Welcome back. This voiceover presentation is going to cover Chapter 15, Mental Health Disorders in Pediatric Nursing, coming from the Davis Advantage text from F.A. Davis. So to begin, you have your learning objectives, basically going to outline what are the concepts and conditions that we're going to focus on in this chapter. So the first thing to remember is what the definition of mental illness is, and to recognize that children and adolescents, there's a great transition that occurs within these developmental phases. A lot of reorganization that takes place, and because of that, we see a wide variation in what is considered normal developmental behavior. You'll find that many of the conditions, the caregivers and even the providers can start to see evidence of them pretty early on in childhood, but they're not always diagnosed early on because they want to determine if some of this is just maturation, continued development of the brain, specifically the prefrontal cortex, before they give some kind of diagnosis that's then going to follow the child into adulthood. Know that once a diagnosis is received, there is a lot of grief that family tends to experience, especially the parents, in that they are losing what they anticipated was the normal development of their child, or maybe a particular future that their child was likely to have if they had not been diagnosed with this mental health disorder. Also know that, understanding what's age appropriate cognitively and behaviorally for children is going to be a big factor in when we can establish if something is normal development or is evidence of some form of condition or diagnosis. And we see a lot of atypical behavior among kids that a lot of times they do end up outgrowing, or it might be environmental related, and so it's not necessarily something that's going to be diagnosed. With the etiology of a lot of mental health conditions, there are links to there being some form of genetic influence, things like autism, lots of learning and language disorders, ADHD. So sometimes it's something that's there since birth and it may or may not be noticed right away. Sometimes it's, like I said, environmental or psychological influences, like a stressful season or a big life event. Their personality altering can impact it. Other times there's other social factors like relationships or culture, religion that are going to play into it. And then there are obviously things we know to be truly neurochemical imbalances. So a deficiency often in things like norepinephrine, serotonin, dopamine can cause some of these conditions. Some trends to be mindful of in terms of pediatric mental health is that the adolescent brain does continue developing even into the child's early 20s, and that maturation takes place from a back to front progression, and that young people in general are more likely to have or engage in these risky or risk-taking behaviors because a lot of times their mentality is they're invincible, they're the exception to the rule. Whatever are the cautionary tales are not going to be the case for them, and that can have some pretty negative effects on their health. It might be that they try some kind of substance and think they're not going to become addicted, but then they do. It may be that they're going to, this one time ride with somebody who's had something to drink, or maybe they're not buckled and think they're not going to be an example of a fatality in that event, and then they are. And so one thing to know is, we want to definitely, as healthcare providers, encourage these caregivers and these adolescents, to seek help when they're experiencing some of this emotional distress, because it really can impact their safety. And just in all regards, reducing the stigma, of needing help. Like, we go to the doctor for things for our body all the time. It's okay to see a doctor for our mind or for our brain or for some of our psychological needs as well. So some settings to consider in which these individuals will be assessed would be in the school system and also in their primary care facilities. A lot of times, symptoms will be noticed, but they will tend to worsen as the child gets older, especially at the time of puberty. We see a lot more change happen with all of the hormonal changes that happen during the puberty transition. And some of these factors, again, can be biological, social, or psychological in nature. The most common conditions that we're going to look at are going to be grouped into one of these categories. Learning disabilities, ADHD is an example of that, and then behavioral conditions as well. And things to note, even in terms of like suicide, we want to make sure that we're asking the right questions. We don't want to think that by asking about it, we are giving the person the idea. That has been statistically disproven, that if a person's planning it, they're planning it, and you are not going to create that thought for them. So we always want to ask if they have a plan, if they have means to carry out that plan, because that's how we intervene, hopefully, before there's any life-altering experience. Okay, so settings in which they're going to receive care for mental health issues. That will depend on what the diagnosis is, the child's age, and what their environmental setting looks like. But a lot of times you'll see them set up to meet with a school counselor. Sometimes they will have a home therapist that comes to their house. They may be an outpatient therapy where they see a psychiatrist or psychologist on a regular basis. Some individuals have to be in like a group home or some kind of residential treatment, or maybe inpatient at a psychiatric unit. So there's various places that children in the pediatric realm will receive care for their psychological conditions. A term to be familiar with is therapeutic milieu. This is what we refer to as like the environment of care in the mental health setting. And so it includes things like people go by their first name. You don't typically disclose your last name because, if somebody is set off, they might be dangerous or harmful to somebody, and knowing the person's first and last name or their address or any of these identifiers can put that person in danger. Other things are like, they are searched to make sure that they don't have anything on them that could be weaponized. Know that the care that they're going to receive, the treatment modality will differ depending on, again, what's going on, but a lot of times they'll be in group therapy sessions, they may attend community meetings, they may be in some kind of psychoeducation classes. We obviously know that sometimes they need one-on-one care, so they may be in a setting where they are, never left without supervision. And these individuals should be checked on very frequently. The assessment, trends or rounds for these are way more frequent or periodic than, assessment in, say, like a med-surg capacity for a patient. Some other things to note in your book, we'll talk about these, some other ways to try to increase health promotion in terms of safety is to have like a contract for safety, where the individual is, agreeing not to harm themselves or to harm somebody else. Oftentimes they may need restraints or they may need to be secluded. These should obviously be last resorts, and they do require a physician's order, but sometimes it is necessary for safety. And as soon as the person is deemed safe again, these restricting measures like restraints and isolation should be removed. So what are some differences in the approach to therapy for pediatrics? Well, the main thing that you'll see is that the effort is to make it fun. As much as can be engaged in this, that provides, the ability to play, the ability to do something artsy or crafty, to incorporate music. Pet therapy is an example. The more fun it's made to be, the more compliant the individual will be, and probably the more beneficial it will be for them as well. Sometimes, what they need is what they consider talk therapy, where they just get to, verbally process some of their problems, thoughts, behaviors, and learn some new coping mechanisms along the way. know the differences between the two forms of behavioral therapy, cognitive and dialectical. The main difference is that cognitive behavioral therapy, the focus is on distortion of thoughts, where it's manifested by different moods and behaviors, whereas DBT, that's a way more intense and structured therapy, because usually this is due to maladaptive behaviors that make the patient unstable. Things that would include self-harm, suicidal ideation, homicidal ideations, those sorts of things. We want patients to be in school if they can be, and there are, laws and acts in place to protect their rights as, individuals that can be streamlined with their peers. So, many times these individuals are going to have what they call like a 504 plan, or like an specialized individualized education plan, IEP, to meet whatever accommodations they have. And it's going to establish specific goals that are going to be, pertinent to and individualized to that patient and their needs. And these should involve as many individuals as possible: the parents, the teachers, the counselors, the SPED, program administrators, principals in the school, as many people as can be involved to make sure that the child's needs are being met. Okay, when we're looking at learning disabilities, some things to consider is that, a lot of it, like I said, is not going to be diagnosed too young in the child, because it could just be a delay in their cognitive or developmental function, and they don't want to label them as having a learning disability that is only, there because they have a slower developmental timeline. But what we typically see with learning disabilities is that they do interfere with the child's, basic life skills, things like writing and reading and math or arithmetic. And it can worsen. It can include things on the higher level as well. So some words you're going to, hear about are like executive functioning. That's the ability for a person to organize, to plan, to reason through things. And when that executive functioning is interfered with, then they struggle with a lot of these higher level skills. It does appear to be more often males that have these learning disabilities, but it can affect our females as well. And they've done statistics, that have said that really 1 in 3 individuals have some form of a learning disability, many of them what they would consider, ADD or ADHD for that. Sometimes the issues with the learning disabilities are stress related, and again, could be a temporary thing and not necessarily a long-term concern or problem. And many times, what they need is more effective coping skills that are going to help them to address stress in their life. Crisis intervention, that's typically when we see like something trigger an episode or a season of difficulty for the child, whether that's learning or behavioral. It could be the death of a loved one, it could be losing their home, it could be separation of parents, anything that is like a critical incident that happened. It's going to be time limited, can have a lasting impact, or can just be a temporary impact. And what's crisis to one person may not be to the other. That's a very individualized thing to consider. When looking at concepts, things to consider, is what the focus is going to be for those interventions. Something that's empathy-based is, you trying to understand where they're coming from, having the person explain things, help me understand how you're feeling or what you're thinking. Entropy is basically meaning, not to engage with them. You want to become calmer and quieter and demonstrate control of yourself as the healthcare provider, because the alternative is that we're going to add to the chaos of the situation. And so, sometimes when individuals are having, like, let's say in the sense of an OCD individual who's having to complete some kind of obsessive compulsive task that they do, we don't want to challenge that. We don't want to, interrupt that. We want to let them finish that process and then try to, speak with them about, well, why do you think you do that? What potentially could be done instead of that. Because if we're trying to interrupt some of their tendencies to cope, then we might actually make things worse. Okay, in the subject of personality disorders, just know that this is something that is very often diagnosed once the person is an adult, by definition, 18, 21 or older. Very rarely will they diagnose a personality disorder in a younger child, because we know that there are so many, childhood experiences that can influence a person's personality, and it doesn't mean that they are developing a personality disorder. Now, a person's personality or temperament is usually developed by age 2, like their, natural tendency to either be an extrovert or an introvert or moody or pretty calm. But, we expect that this diagnosis is going to come age 18 or after. A lot of times, again, due to brain development as well. So borderline personality disorder, which again we see usually exhibited in adolescence, is characterized by things like self-harming, having an identity disturbance or multiple identities, their thoughts and feelings and actions being inconsistent, and that's usually due to these multiple personalities that the person is experiencing. It's going to result in unstable relationships and attachments. This person may have some over-idealized or fantasy of what that relationship looks like, and it's going to interfere with their, cognitive function. So, they have disturbed thinking patterns, they have impaired problem-solving skills, they're impulsive, and that's typically, the behaviors that are going to persist that are going to lead to this diagnosis for an individual. We talked about executive functioning already, that higher order thinking, organization planning, sequencing, self-regulation, and even memory. These issues common with learning disabilities like ADHD, but they can be helped with, management like medication and things of that nature. So know that that's typically what we're trying to do with these individuals, is give them coping skills and maybe other treatments that are going to improve where they're deficient. Okay, attachment disorders. This a lot of times it really does boil down to what the child's relationship is like with the caregivers in their lives, like parent-child relationship, like in the instance of a family that ends up divorcing and the child's kind of shuffled between the parents might be a problem. A family who has, say, like a drug problem and the child's often neglected can make a difference. A child that's been removed into, state custody and is now in the foster system, maybe even adopted, may still struggle with some attachment disorders, obviously, if there was abuse present. So it's going to be what we consider like a cornerstone for them to have a positive parent-child relationship, because it's going to influence all future relationships for that individual. So what do mood disorders present like? Usually they're going to be a disturbance in the person's emotional state that actually impacts how they can achieve daily activities of living. So ADLs are affected. For example, somebody who's depressed, they don't necessarily care about their hygiene. They don't often want to get out of bed, put on clothes. They may not eat properly or often. So it's something that's going to interfere with that. And in bipolar disorder, which has the depression and the manic phases, can still do that too. Even somebody in a manic phase can still be neglecting their daily activities. A lot of times they're so all over the place that, they're not managing their bills. They're not eating, a nutritious meal program. They may not be taking care of themselves in terms of their hygiene and other important responsibilities like that. So looking at depression specifically, I want to point out something that's in your textbook. It's on page 341. It's an acronym called SAD faces, and it's really important that you familiarize yourself with this because you will see this in the exam. But basically each of the letters has represents some concept that is evaluating a patient for depression. So the S stands for sleep disturbances. A lot of times with depression, there's some either the patient sleeps a lot, or maybe they have trouble sleeping at night. They sleep during the day, so it can have alterations in their sleep patterns. Anhedonia, which you probably have heard of before, is that, not having pleasure in things that used to bring pleasure. So maybe, typically you would have enjoyed being around other people, listening to music, interacting, and now there's no enjoyment there. The D represents despair, the F, fatigue. A in this second word represents appetite changes. The C is for concentration, E for emotional sensitivity, and the S for suicidal ideation. So know that they're never too young to be evaluated for depression. We might think of that as being something that's usually an adult problem, or even like, say, an adolescent problem, but it can happen in that early formative years too, like the school-age child. And so, even young children can have those thoughts or behaviors. And then bullycide, that's, suicide that is resulting from somebody who has experienced a fair amount of bullying from their peers, and they have developed this mindset that it's hopeless, they're depressed, they're never going to be able to overcome this. And that's becoming a growing trend, unfortunately, in our school-age population also. Socioeconomic factors can play into this. Individuals that lack social support. If this child has experimented with substances, it can largely increase the chance of them experiencing depression, or even early sexual activity. All of that can contribute to, mental illness and manifest as depression. We do know that obviously medications help. Just know that the protocol for pediatrics is skills before pills, which means therapy should be the first line intervention before going straight to antidepressant medications. And once medications are, deemed necessary, the, protocol is start low and go slow, which means you're going to use the lowest doses of those medications and titrate them slowly to determine their benefits, because, we don't want to create more problems in that effort. Know that a lot of medications are not studied in the pediatric population, so they're therefore used off-label, and they do need smaller doses more often throughout the day for the effects and benefits, and to avoid some of the side effects. Know that with starting antidepressants, it takes, usually up to a month for it to be noticeable in its impact. And during that time, it's actually very common for suicidal ideations and other self-harming thoughts to escalate. So we definitely want to be in constant communication with our patients who are, beginning treatment with antidepressants. The goal, of course, is to balance out the neurotransmitters, without as much as we can without the side effects. So the first line treatment is going to be SSRIs, and they're listed for you on the slide, the more common ones being Prozac, Zoloft, and Lexapro. But know that truly depression is not curable. It is something that, is going to typically have different exacerbations over time, so the medications are being used to reduce the symptoms and improve the patient's quality of life, but not truly cure or correct the imbalance. And then side effects that we tend to see with these medications, they are going to include things like GI upset, dry mouth, sexual dysfunction. Even some patients experience like orthostatic hypotension, but know that the SSRIs tend to have the least troublesome side effects of the different medications out there. And make sure that we're looking not just for suicidal ideations, but other forms of self-harm like cutting or headbanging, because that tends to be something that people experience, especially in that first month or so of treatment. Okay, bipolar disorder. This would be the depression that's paired with phases of mania or manic behaviors. Usually these shifts happen very abruptly without necessarily any, obvious trigger, but it's going to affect the patient's mood, their energy and activity level, and their ability to think clearly. And it tends to interfere with their, daily life and functioning as well. Excuse me. With bipolar disorder, the mania can be more than just happy, excited, very eager and busy personality. It could also have the presentation of rage, in addition to other symptoms as well. So we're looking for, the depression, but we're also looking for any form of mania, besides just the happiness could also be like the rage patterns. These patients typically need extended release medications, ones that have longer acting function, so that they can help to control and balance the patient's moods for a lengthier time. And what typically we'll see is some drugs that are actually used off-label in pediatrics for bipolar disorder, like Depakote and Clonidine. Depakote is an anticonvulsant and Clonidine is a hypertension drug or antihypertensive, but both of them have mood stabilizing effects on youth. So that's actually something very common to see prescribed for these individuals. Another would be lithium, which is a stabilizer. It does have a lot of side effects associated with it, like GI upset, urination and thirst that's hard to satiate, and weight gain. So many times we'll see patients not want to be on these drugs because of their side effects. Okay, anxiety disorders. Very, very typical in pediatrics, becoming more and more common, I think, in the last 20 to 30 years. And a lot of times it's hard to diagnose because the child may not be able to verbally express that what they're experiencing is anxiety by definition. A lot of times they're going to have complaints of, like some of those somatic symptoms like a headache or GI disturbances, things that are hard to prove or disprove. But what really is the ultimate, trigger is this persistent and excessive worry that they're experiencing. And it will typically interfere with their daily activities. So, being mindful of what some of these symptoms may actually be linked to. This is probably the most common thing we see in pediatrics, and it can be anxiety in the way of, school performance, like test taking anxiety. It can be separation anxiety in our younger kids from their primary caretakers. It can have many different forms that it manifests. So in instances where, medication is needed for anxiety, it's important to identify if the anxiety the patient's experiencing is considered acute or chronic because they're treated differently. Acute anxiety, typically, associated with certain, factors in their environment or seasons of their life, may be managed with things like Vistaril and Benadryl, which are actually antihistamines. And because of their sedative properties, they tend to help calm the body in that situation. Whereas Buspar is something that we would use for chronic anxiety. Vistaril and Benadryl wouldn't be recommended for chronic because of their addictive tendencies. We don't want the patient to become dependent on these things, so we use them in a crisis, but not for long-term care. But Buspar doesn't have that addicting property, so it can actually be one that's used on a long-term timeline. It doesn't have the sedative effects, and it is non-addicting. Sometimes you'll even see SSRIs used for chronic anxiety as well. And then we have within this topic obsessive compulsive disorder, or OCD, where a person experiences compulsions, and those are typically their way of coping with the anxiety sensation or feeling. So a lot of times it's these unwanted thoughts and behaviors that are recurring, and it does tend to interfere with quality of life, but our effort to complete them is what's trying to minimize the anxiety we're experiencing. Things like checking to make sure that you locked your door 5 times, that you turned off the stove. Maybe you have to do some kind of repetitive action, or a particular order or sequence to things that you can't deviate from. There is believed to be some genetic components in it, but at this time, there's really not any way of knowing for certain that that's the case. Under anxiety disorders also comes the topic of phobias, and phobias you would probably recognize as fearing something, and there are a ton of them out there. What you just need to be familiar with is that, a phobia is something in which an object or a situation is feared, and it can interfere with the person's daily living. Depending on what it is, sometimes they're temporary, you can outgrow them, but some persist, lifelong. Things like fear of enclosed spaces, or claustrophobia, or fear of heights, even some people, social situations. And what we tend to see as the indicator is their avoidance of those things. With panic disorder, that is when a person experiences an overwhelming sense of dread, and it tends to, display as attacks or exacerbations. The patient starts to experience some systemic responses to this, so it may manifest as dizziness or faintness, or like their heart rate is beating rapidly. And so many times in this, the patient is experiencing like a period of extreme stress that's triggering this panic disorder occurring. Another thing to note would be PTSD, or post-traumatic stress disorder. That's typically triggered by some kind of traumatic event, and this is the consequence of it. And so typically something is going to remind the person of that trauma and cause them to experience this traumatic experience. So flashbacks to it could be an example, and something that I even learned in y'all's textbook with this topic is that anytime a person experiences significant trauma, if they can be treated right away with a dose of propranolol, Inderal, that can actually decrease the chances of them experiencing the PTSD symptoms. Now, it's not beneficial if there's a lag in the trauma experienced and the treatment with the medication. But if they can, follow up that trauma pretty quickly with this medical intervention, it can actually decrease the risk of PTSD in that individual. Okay, so these disruptive disorders that are mentioned, ADHD, ODD, and CD, we're not testing on them. My understanding is in Psych Nursing 318, y'all had covered them heavily, and there's not any additional information since these are pediatric primarily conditions. So my expectation is that y'all have learned them for what they manifest as and how they're managed, and you won't be given any test questions that are specific to these during this content. Now, keep in mind, like ADHD, that is one of the most common, mental health related conditions in pediatrics. It still may be, brought up within an exam question in some capacity. Anything you've learned up till now in the program is testable in this course, but it's not going to be the focus. We're going to focus on things that y'all haven't had or maybe didn't have in the pediatric realm. Okay. Impulse control. So with impulse control, what we tend to see with these individuals is they have this inability to resist the urge to do something that is either wrong or harmful. And this typically develops in that school age time frame as we're approaching puberty and approaching adolescence. Things like kleptomania is an example, when they steal things, or pyromania, when they, have an infatuation with fire. But it could be even as severe as like schizophrenia, where they have, audible and visual delusions or hallucinations that can impact their behavior and their speech and their social skills. So there's a variety, of examples, but we're not going to get into really the depth of any of those in this course. The next thing to look at is autism spectrum disorder, or ASD, which is something very commonly diagnosed. And I think that it probably always was there, but maybe a lot of the changes that we've experienced as a culture in this country has really increase the prevalence that we see with it, or maybe just more knowledge of when certain behaviors a child should outgrow them versus they have persisted, to give us this indication that we may actually have something diagnosed in this kid. But what typically happens is it's a developmental impairment that affects the person's social skills, even like emotional attachment, how they communicate or play, and their behaviors tend to be impacted. Many times, we'll see evidence of this as early as like 18 months, but the diagnosis won't come until, they're 3 or 4 years old. Some of them not even until they're in school, because again, we want to make sure it's not just a delay in cognitive changes or something that their environment could actually have impacted and could improve. Because once that diagnosis is there, it is really hard to have that, removed from the patient. For some, this is also going to manifest as like a sensory disorder, and sometimes that's the way in which they are, linked to autism spectrum, but in reality, this sensory processing disorder is something that they can outgrow. And so, what we tend to find is if we can increase their stimuli for these short periods, it will build tolerance and then ultimately teach them the coping mechanisms needed to handle those, alternative sensory stimuli later on. Things like fireworks or loud noises or thunderstorms tend to be some of the things that are examples you might find. Okay, on eating disorders, this is probably a familiar concept for you, having come from psych last semester, and some of this information obviously being in other courses in the program, even prereqs. But I just want to focus on a couple of things specific to peds and these particular conditions. So with eating disorders, a primary consideration is that, we see it the most in the adolescent population, females more than males, but not excluding the male, because that's when they become most fixated on their self-image and peer opinion. Peer pressure is the greatest in this developmental phase within the pediatric time frame. So be something that you associate with how we're going to assess this individual, at that adolescent phase, is by asking about their nutrition patterns and trying to ensure they're not exhibiting indicators of an eating disorder. They can be very serious because of the disturbances they have in your body's electrolyte balance, and they can also even be fatal depending on the severity of malnutrition the person's experiencing. Compulsive eating or compulsive overeating, which is the last bullet on this slide, by definition, it's the binge eating disorder that you see with bulimia, but without the vomiting. So it's an addiction to food, and it's eating beyond what is needed to feel full or satiated. But with compulsive overeating, the person does not purge. Okay, so that's how those differ. But anorexia and bulimia should be familiar to you. Anorexia being the reduction in what the person eats, so very minimal intake due to this, distorted body image and this desire to be very thin. Bulimia is the eating but then binging and throwing up, follows it. An indicator a lot of times that we see physically with bulimia nervosa is Russell's sign, which has to do with the knuckles. So the patient, creating that self-vomiting, triggering that, they'll put their fingers on their throat, and so they'll begin to have like some skin breakdown to their knuckles. Another would be eroding enamel on the teeth. due to that regular vomiting and the acidity of their vomit. So some things to consider as assessment parameters. Substance-related disorders, this is when somebody abuses the use of substances that do impact their function and can, impair them. We know that in the United States, accidental death related with drug overdose is becoming one of the most prominent causes of death. This includes vaping devices that students or children, pediatrics, are experimenting with, but also taking pills, both prescription and things that, are on the streets. Know that, it's very common for pediatric patients in the adolescent years to be exposed to this, to be pressured to participate in this, and to even have tried some of this. And so, never think they're too young to be bringing up this topic and trying to educate on this topic. Vaping is, of course, one of the more popular or common forms that teens have access to and are using. It's also considered a gateway drug, so once they are comfortable with that, they're more likely to experiment with other things. Things that could be an indication of inhalant use would be, say, mouth ulcers, so something to evaluate and ask questions in regards to. And know that sometimes these individuals will actually have more than one diagnosis, so they'll have the primary mental health condition, but then they may have something like substance use on top of that, and it could be their way of trying to cope or self-treat some of the mental health conditions that individuals experience. Childhood abuse, I think we've covered this already in some of the developmental content, but know that, as a healthcare provider, you are a mandated reporter, and so it is something that you want to be aware of how it presents, but also how it's managed or how you intervene when it's suspected. Bruising is generally going to be an indicator, especially if it's at different stages of healing. It could be, somebody coming in with different broken bones or a history of fractures. It could be that the person has some, very noticeable aggression or behaviors where they act out. They may even report not sleeping well or other somatic complaints like chronic headache or stomach upset. So, it's not always just the visible indicators that you need to be aware of. You want to ask the child these questions in a safe and private environment, if at all possible, without caregiver present, because that's when they're likely to get, more truth from them. Know that abuse can happen in many different, capacities. So there's obviously sexual abuse, physical abuse, but also verbal abuse, and even neglecting the patient is a form of abuse. We're not going to have any questions pertaining to Munchausen syndrome by proxy, but that's something else that fits in this category where, the parent creates essentially symptoms for the patient, usually due to some issue that they have mentally. And that tends to be a situation where the patient's brought in often for these erroneous problems that may or may not actually be wrong with the patient. Okay, that actually completes the Chapter 15 content. So, when you're going through this information again, looking at the PowerPoint slides and the textbook, just be mindful of what topics we covered in the PowerPoint, because there are going to be additional things in the chapter that we're not testing on or that we're not teaching, either because they are less common in the pediatric population or because you've already had it to an extent in other courses in the program. But that will be the end of our Chapter 15 content.